So good morning, and thank you to all of you who have come today. We had a very interesting meeting this morning and a lot of ground to cover. So before we begin, I just wanted to go around and do a set of introductions, particularly because there may be some of you here in the audience who haven't met all of us. And we do have a full committee today, which is terrific. I'm Wendy Everett. I'm the interim chair of the Quality Improvement and Patient Protection Committee, and have been the person who's run the public hearings and been involved with this particular topic around nurse staffing ratios in the ICU since its inception. I'm really thrilled today to be able to introduce a new member both of the commission and of this committee. So Marty Cohen is sitting to my left. Marty was appointed by the Attorney General, Warren Healy. He's currently president and CEO of the Metro West Foundation and has worked for the Robert Wood Johnson Foundation and for the Executive Office of Health and Human Services for the Commonwealth in the past. So welcome, Marty. We're really thrilled to have you here. So if we could just quickly go around the table. Veronica, starting with you, if you just would introduce yourself and your affiliation so Marty can know who we are and the people in the audience.
Welcome, Marty. Veronica Turner, Executive Vice President for 1199 United Healthcare Workers East. We represent 52,000 healthcare workers across the state.
Good morning, Alice Moore, Undersecretary of Health and Human Services for the Commonwealth of Massachusetts, and here as the designee for Secretary Mary Lou Sutters.
Thank you. Want to say hello?
Thank you, Wendy. It's a pleasure to be here and to serve. And officially sworn in this morning, so I officially am the new king.
I'm Carol Allen, pediatrician, retired from practice.
Great. I'm David Saltz. I'm the Executive Director of the Health Policy Commission. Welcome, Commissioner Cohen.
And I'm Lois Johnson. I'm the General Counsel of the Health Policy Commission.
And I will introduce Jen in just one moment. Our agenda today has 3 issues on it. So we're now going to move on to a committee discussion of the final regulations and quality measures for the nurse, the nurse staffing ratios for ICUs. And before I turn the meeting over to Lois Johnson, I did just want to thank all of you here in the room and those of you who aren't for the incredible amount of effort, time, thought, and real kind of passion and intent that went into both the testimony at the public hearings and in the written testimony that you presented. These regulations are complicated and difficult and tied back into a piece of legislation that also was complicated and difficult. And I personally and the staff and the committee are extremely grateful to all of the input that we got. Out of that input, we listened very carefully. We have changed many of the proposed regulations, so they will look quite different as Lois goes through them today. And by and large, I think that we have come to resolution on the majority of the issues on which you testify, with one exception. And that is a very important exception that we want to have enough time today for the committee to discuss. And that exception is, what is the definition of an intensive care unit? It's important because it has legal effects, it has policy effects, and it has cost effects. So I will focus the discussion of the committee on those three issues today. Lois has very graciously agreed to slightly alter her presentation so that the discussion of that definition comes at the end of her presentation, and we really then will have the time to focus on the committee's reactions and their positions on that particular issue. So before we begin, just any further questions or comments about the process I've outlined from the committee members? Okay. Lois, thanks again, and I'm not sure whether David's going to make just an opening statement, and then we'll turn it to Lois.
Great, thank you, Commissioner Everett. Before we begin, just a housekeeping item. Given if the committee votes to advance the regulation today, we will have printed copies of the regulation for you here when you walk out, both a clean version and a red line version. I know that's important. They will also be posted on our website. For the changes to the Office of Patient Protection regulations, we won't have printed copies here today, but those will also be available on our website following today's meeting. So did want to give you that update for many of you who will be wanting to look through the regulation in detail. Want to emphasize one point that's already been made, which is just from a staff level, gratitude to everyone in this room who has engaged with us throughout this 9-month process. I'm proud of the thorough and extensive process that we've engaged in with the guidance of the commissioners and with stakeholders. We have, at a staff level, learned a tremendous amount in this period of time. And as you'll see from Lois's presentation, really reflected on all of these learnings to craft something that we think is workable for the Commonwealth, that keeps patient care at the center while fulfilling our responsibilities under this law. So thank you to all of you. I will make those same comments, I think, at the full board meeting, should that happen. To walk us through all of the thorough analysis and the recommended changes, I'm going to turn it over to our esteemed General Counsel, Lois Johnson, and I do want to introduce two other lawyers who will be doing parts of the presentation behind me, Kate McCann and Lisa Snelling, who are also counsel with the Health Policy Commission, and this is the team that really has been working on this issue for the last year. So with that, I'm going to turn it over to Lois.
Thank you, David, and committee members. Kate and Lisa can join us at the table. Good morning. As David mentioned, I'm joined by Kate McCann and Lisa Snellings, and together we will present to you today our recommendations for the final regulation to implement the nurse staffing law, which, as you know, is codified in Section 231 of Chapter 111, which is on the slide. The law requires a patient assignment limit of 1 or 2 patients for registered nurses in intensive care units, depending on the stability of the patients as assessed by the acuity tool and the staff nurses. And as you know, the law requires the Health Policy Commission to promulgate regulations on the implementation and operation of that law, specifically with regard to the formulation of the acuity tool, the public reporting of staffing compliance, and selected quality measures. This next slide, which we have presented,
Slide 13.
We have presented this slide to the Commission previously, but as you can see, shows the arc of the regulatory development process from the early days of public listening sessions to the release of proposed regulation on January 20th of this year through our public comment period, which closed on April 13th. We have, as both David and Wendy have noted, prioritized extensive stakeholder engagement throughout this process, with significant outreach to and input from hospitals, nurses, experts, consultation with the Department of Public Health, as well as multiple touch points with you, our commissioners, and others. We have learned a great deal and heard many different perspectives on this law and on this regulation. The next slide shows by the numbers our recent public comment process. Over 225 people attended our 2 public hearings, one of which was in Boston, the other in Worcester. 45 people testified at the hearing, and we received subsequently 48 written comments during that period. These comments on the proposed regulation we found extensive, thoughtful, detailed, and really underscored the complexity of the issues raised in the law. We appreciate all of the testimony we received from nurses, hospital administrators, patient and consumer advocates, legislators, quality experts, and many others. Topics addressed in these comments included the acuity tool, the definition of ICU, the timeline for certification, the role and composition of the advisory committee and patient assignment, and many others. So before walking through these issues this morning, I wanted to frame our discussion on the next slide with some principles we use to approach the final regulation. First, recognition of differences between hospitals and different ICU types. In keeping with our approach in the proposed regulation, the recommended final regulation we present to you today also seeks to balance the statutory goal of safe patient-centered care with the flexibility necessary for hospitals to address unique circumstances affecting each ICU. And for that reason, we continue to emphasize the process by establishing guidelines for the selection or development of the appropriate acuity tool, rather than being overly prescriptive about what the tool should look like in each intensive care unit across the Commonwealth. Second, another principle is recognition of the role of ICU staff nurses. As confirmed over and over again in the testimony and comments we received, just as the ICU nurse is an essential, critical part of the ICU care team, the voice of the ICU nurse is important in the implementation of this law. The final regulation continues to provide a meaningful opportunity for staff nurses to participate in the development or selection process, to provide input on the tool and its use. As we discussed, we've clarified and enhanced staff nurse participation in this regard. Third, consideration of administrative burden. We were mindful that this is a new law, and with that brings new hospital reporting obligations. The final regulation requires reasonable reporting and record-keeping requirements to support compliance, but seeks to minimize burden where possible. Finally, recognition of the role of the Department of Public Health in its implementation of the law. As we developed our regulation, we were cognizant throughout of the companion role of the Department of Public Health, which certifies the acuity tool under the statute, and as the regulatory agency responsible for hospital licensure, will oversee staff and compliance. We recommend, therefore, certain refinements in the regulation to reflect deference to the role of DPH, and relatedly, also to reflect the goal of hewing close to the HPC's specific statutory charge, so resulting in excluding issues not specifically addressed in the statute. So turning to the proposed regulation, this slide shows an outline of the final regulation, and our plan this morning is to walk through key issues, highlighting areas of comment and identifying those issues where we are recommending changes to the regulation. And I want to just pause here to make a few notes. You may note in the draft that we are recommending a change to the title from registered nurse to patient ratio in intensive care units to using the phrase patient assignment limits for registered nurses in intensive care units. We believe this more accurately describes the law's requirements. And while we use the term ratio and patient limit somewhat interchangeably in our discussion, we believe that it's appropriate and provides more clarity to use the term in the title. We also recommend a related change in 8.01, the section describing the regulation scope and purpose. For clarity, as you will see in the regulation, we also included new defined terms in section 8.02, simply moving language used elsewhere in the text to make new definitions. That includes clinical indicators of patient stability, indicators of staff nurse workload, and critical environmental factors. So moving to the first issue, one of the major areas of comment that we received was whether the law requires the regulation to incorporate a default nurse-to-patient ratio of 1-to-1. That is, the assignment of one nurse to one patient. The statute states that the patient assignment for the registered nurse shall be 1-to-1 or 1-to-2, depending on the stability of the patient. We received several comments asserting that this language was intended to require a default 1-to-1 staffing assignment, with a 1-to-2 assignment only permitted where the patient is stable enough upon assessment to require less intensive nursing care. We do not recommend a change to the regulation on this point. The regulation does reflect the statutory language of 1-to-1 or 1-to-2, and does not otherwise require acute hospitals to implement a default patient assignment of one nurse to one patient in ICUs. That said, a 1-to-1 ratio should result in appropriate circumstances based on the assessment of patient stability with the staff nurse and the acuity tool. Nothing in the regulation would prohibit a hospital from implementing a tool that uses 1-to-1 as a baseline staffing approach in a given ICU with particularly higher acuity patients or particular environmental factors that warrant it. The next slide addresses the application of limits to the unit. The statute requires compliance with nurse staffing requirements in intensive care units, and uses the term units. The proposed regulation therefore reflects that statutory language and specifies that the staffing requirements apply to all patients being cared for in intensive care units. Some commenters objected to the unit-wide application in the regulation, suggesting instead that the staffing requirements should apply only to critically ill patients in the ICU as opposed to all patients in the ICU, because not all patients in an ICU may be critically ill, and this, they raised, is especially true in a community hospital setting. Often there are lower acuity patients for whom transfer or discharge is not recommended. There may be boarders. The ICU may house certain specialized technology or equipment, and there may be patients with unique care needs. Accordingly, they requested a change to the definition of ICU patient to distinguish such patients that don't require such staffing intensity. We recognize that some acute hospitals, particularly community hospitals, as I mentioned, may have patients with lower acuity in the ICU from time to time. However, the statute clearly requires unit-wide applicability of the staffing limit requirements, and the HPC really does not have flexibility on this particular issue, so we're not recommending a change here. I will note, as I'll describe later when we discuss the timeline for certification, that we do recommend a change that reflects the unique challenges faced, in particular by community hospitals. The next slide addresses the issue of the language included in the proposed regulations of at all times. The proposed regulation stated that the patient assignment for each staff nurse shall be 1 or 2 ICU patients at all times during a shift, and the maximum patient assignment for each staff nurse may not exceed 2 ICU patients at any time during a shift. Many commenters supported the inclusion of this language, citing the mandatory nature of the law and the fact that the law does not include exceptions. In contrast, many hospitals commented that the at all times language goes beyond the scope of the statute and creates major operational and financial problems for implementation. They say, for example, that the law would require the creation of a float pool of nurses to temporarily relieve assigned nurses on a daily routine basis, whether for breaks, transporting patients, codes that happen in the unit, or other bedside procedures or emergencies. They also claim that it would significantly increase costs associated with the implementation of the regulation. Other commenters suggested that there should be clarifications to the proposed regulation to address specifically emergency situations. While the language in the proposed regulation of at all times was intended to make clear that the statutory patient assignment limits apply each day and shift, and hospitals cannot elect non-compliance for any reason, it was not intended to impose unreasonable requirements that impede daily dynamic patient care workflow in the ICU. And accordingly, we do recommend removing the language at all times during a shift or at any time during a shift from the regulation. This will allow the day-to-day implementation of the law's requirements to be addressed at the hospital and unit level. Expectations for break coverage, for example, can be addressed in the hospital's policies and procedures and implementation of this law. DPH may also consider issuing guidance on this issue, especially for how hospitals might, as a practical matter, assure compliance while addressing this particular issue. In your packet, we're going to be skipping the next slide. So we're moving to the issue of assessment of patient stability.
Slide 21.
This slide discusses the section of the regulation that describes the process of using the acuity tool in the assessment of patient stability, section 8.05. We propose several revisions here for clarity and precision, as well as in response to multiple comments. First, to more accurately reflect the purpose of this section, we changed the title and focus of the section because it is now related specifically to assessment, whereas the prior section 8.04 is the section on patient assignment limits. We wanted to clarify that for understandability. Second, based on objections of some commenters to the language at the beginning of 8.051, which is for the purpose of determining patient assignment, we recommend removing that language and replacing it with a reference to the section 8.04 on patient assignment limits. Also, based on suggestions of nurse commenters, we recommend reversing the order of A and B, as you see on the slide, to emphasize the role of the staff nurse in doing patient assessments and make clear that the assessment of a patient includes both the assessment of the bedside nurse using his or her judgment and second, the use of the acuity tool. Third, we recommend addressing comments about who is doing the assessing. Nurses commented in particular that the regulation should say that the assessment of patient stability should be done by staff nurses, plural, in the unit. Based on testimony, we do not recommend adopting that approach, but rather recommend clarifying that the nurse assessing the patient should do so with the acuity tool and with his or her nursing judgment. Fifth, based on comment by the nurses, we further recommend adding a reference to other relevant laws that govern nurse practice, including the State Nurse Practice Act, basically saying that all other laws of nursing practice apply. The next slide addresses the issue of assessment of patient stability, and in particular describes what happens if there is a disagreement regarding the assessment of patient stability. You'll recall that the proposed regulation provides that if the staff nurse determines that the ICU patient stability requires a different registered nurse to patient ratio than that indicated by the acuity tool, the nurse manager or the nurse manager's designee shall resolve the disagreement between the acuity tool and the staff nurse's assessment. We received comments about the nature of this disagreement that's referred to in the statute. Nurses commented that the role of the nurse manager is to resolve a disagreement among all of the staff nurses concerning their collective assessment of patient stability, or a disagreement between the staff nurse's collective assessment and the acuity tool's assessment. Based on statutory language, however, we do not recommend changing the language with regard to the nurse manager's role in resolving a disagreement between the staff nurse and the acuity tool's assessment of patient stability. nor the nurse manager's role in ultimately determining the patient assignment. For clarification in this section, we also recommend changing the text so we refer to the nurses assessing rather than assigned to care for an ICU patient. The next issue we want to address is the frequency of patient assessment. This section of the regulation describes the requirements for when the acuity tool must be used for patient assessment. The proposed regulation established minimum requirements. First, upon admission or transfer of a patient into the unit, at least once per shift, and at other intervals or circumstances specified in the policies and procedures developed by the hospital. Several commenters suggested that our regulation require more frequent assessments, some specifying every 4 hours, others suggesting that the tool should be used whenever there is a substantial change in a patient's condition or treatment. Of course, we know that nurses perform ongoing patient assessment, but this section addresses only the assessment using the tool. So accordingly, we do not recommend a change to this section, which establishes, we believe, an appropriate minimum assessment using the tool. More frequent assessments using the tool may be required by hospitals in their policies and procedures, in addition to ongoing assessment by staff nurses. As in the previous sections, we also recommend that the phrase assigned to care for be replaced with assessing. So now I want to turn it over to Kate to address public comments received on the process to develop or select the acuity tool, required elements of the tool, records for compliance and certification, and public reporting.
Thank you, Lois. Good morning, everybody, commissioners. So I think we're on slide 24, and this slide addresses section 8.06 of the regulation, which focuses on the development or selection and implementation of the acuity tool. And as Lois highlighted earlier in covering the key considerations in the development of the regulation, the process elements in the regulation here are really central to effectuating the goals of the statute. You'll recall that the statute requires the hospital to select or develop the acuity tool in consultation with staff nurses and other applicable medical staff. As such, the proposed regulation requires hospitals to establish an advisory committee to provide recommendations on the selection, development, and implementation of the acuity tool to be used in each ICU. The process is intended to promote registered nurse input while giving hospitals the flexibility necessary to select and develop a tool that best meets their patient needs. We received a number of comments on both the role and the composition of the advisory committee. The proposed regulation requires, as you'll recall, that the committee have at least 50% registered nurses who are not nurse managers, a majority of whom must be staff nurses in the ICU. There was a consensus in the public comments that we received that the nurses on the advisory committee should be staff nurses in the ICU, with some comments advocating for at least 50% direct care ICU nurses. Several comments suggested that the committee should have the ultimate authority to select or develop the tool beyond an advisory role. On this last point, the statute precludes the HBC from recommending a change to the advisory nature of the committee. However, based on extensive public comments and to reinforce the role of the staff nurses in the development or selection of the acuity tool, we do recommend amending the composition of the advisory committee to include at least 50% direct care staff nurses in the ICU in which the acuity tool will be deployed. This amendment clarifies that the hospital is required to include staff nurse representation for each ICU in which they will deploy an acuity tool under the regulation. On another point on this slide, even though the exact language doesn't appear on the slide from the proposed regulation, we received a number of comments requesting the removal of the language in what was 806 subsection 3 that referenced additional bargaining obligations of an acute care hospital. Based on the comments and the fact that the language is not required by the statute and is a statement on applicable obligations, we recommend removal of that language. And finally on this slide, we recommend the inclusion of new language in response to comments received addressing how an acute hospital with multiple ICUs might efficiently implement the advisory committee process requirements across their hospital. Moving to slide 25. The proposed regulation requires the acuity tool in each ICU to include a defined set of indicators that incorporate clinical indicators of patient stability and indicators of staff nurse workload. While the proposed regulation does not require the inclusion of specific indicators, it does include, as examples, types of clinical and workload indicators that may be included. Some commenters on this point recommended the inclusion of additional clinical indicators. There are some listed on the slide. For example, behavioral health, vascular, infectious status, other clinical domains, while others said listing clinical indicators was overly prescriptive and recommended the elimination of the specific indicators altogether. Given that the nature of the list was exemplary and the fact that its presence caused a little bit of confusion, we recommend clarifying edits to better reflect the intent to allow flexibility in acuity tool design for each ICU in which it will be deployed. We recommend including, as Lois mentioned earlier, general definitions of clinical indicators of patient stability and indicators of staff nurse workload in the definition section and removing the example indicators from the text in 807 altogether. As a final point on this slide, just a technical clarification, we recommend removing what was 807 subsection 5 in its entirety as the requirement is reflected elsewhere in the regulation. Section 8.08, I believe we are on slide 26. Section 8.08 of the proposed regulation addresses records of compliance. I'll address the records in each of the subsections in turn. So we'll begin with 808 subsection 1, which outlines the records required for retention regarding the development or selection of the acuity tool or tools, as seen in the top part of the slide in front of you. Some commenters stated that the requirements for retention of records here about the development or selection process are overly broad and burdensome and question the length of time for retention. The HPC is cognizant throughout this process that this is a new requirement for records retention for acute hospitals and certainly understands the administrative implications of such requirements. However, the retention of these records regarding the development or selection of the acuity tool or tools is important for compliance purposes. At the same time, we recommend further specifying the types of records that must be retained to satisfy these requirements. Further, based on our consultations with the Department of Public Health, we do not recommend amending the 10-year retention requirement. Lastly, one clarification, 808 subsection 1C and D, we recommend the removal of them as the requirements are reflected elsewhere in the regulation on a section on implementation of the acuity tool by the acute hospital.
Okay, just a clarification. In terms of consulting with DPH, is the 10-year retention rate their requirement?
It is their recommendation for this part of the regulation, yes. The second part of section 8.08 pertains to records required for retention on staffing compliance. Here as well, some commenters stated that the requirements are overly broad and burdensome and that the retention requirements would effectively eliminate the option to have a manual acuity tool. Others urged that the regulation should specify that the patient assessments and resulting patient assignments must be documented in the patient's medical record. As in the prior subsection, the HPC understands that this is a new records requirement for acute hospitals, but based on our consultations with DPH, we do not recommend amending the 10-year requirement, as the documentation is necessary to support DPH's compliance responsibilities. Nevertheless, we do recommend clarifications of the records required to be maintained for staffing compliance. On the particular issue of documentation, I'll touch here to say we do not recommend specifying that the results of assessment and patient assignment must be documented in the patient medical record. The regulation prescribes the records that must be maintained and for how long they must be maintained, but acute hospitals retain the flexibility to determine the applicable and appropriate mechanism for documentation and retention consistent with existing state and federal law governing records that include individually identifiable health information. For example, we understand that such records, are required to be kept and made available to patients under federal HIPAA laws. On the next slide, section 8.09 in the regulation addresses the statutory role of DPH in certifying the acuity tools. I would note here that most of the comments received on this section actually pertained more specifically to the certification timeline, as they're closely related, as will be discussed later in the presentation. And here we recommend amending this section in order to provide the flexibility to DPH in its development of certification and compliance requirements. Additionally, we propose a minor amendment to the section title for clarity. The next slide addresses section 8.10 of the regulation, which governs public reporting on nurse staffing compliance. As required by the statute, the HPC must identify the method of reporting to the public on staffing compliance in hospital ICUs. Some commenters here urge the removal of the requirement for hospitals to post reporting on compliance on their websites, saying it's duplicative, and suggested revisions to reflect existing annual reporting to DPH via their healthcare facility reporting system. Other commenters urged a requirement that a copy of the law be posted and visible in the ICU waiting areas and posted on the hospital website as well. Here, we recommend amending the regulation to provide greater flexibility to the Department of Public Health regarding the determination of the frequency and manner of reporting. Additionally, we recommend simplifying the method of website reporting by acute hospitals to require posting the very same reports submitted to DPH. Further, based on public comments, we recommend removal of the requirement to report to DPH on any instance and the reason in which the minimum ratio of 1:1 or 1:2 was not maintained by an acute hospital, as seen in 8.10(1)B of the proposed regulation. Finally, on this slide, we do not recommend that the regulation require either posting or notice to patients of the requirements of the law, as that is outside of the regulatory scope. Slide 30 addresses section 8.11 of the regulation, which outlines the requirements for the collection and reporting of quality measures. I will briefly address comments received and recommendations to this section, and then I'll turn it over to my colleague Lisa Snellings, who will present our recommendations on the quality measures themselves. As you'll recall, the statute requires the Health Policy Commission to identify 3 to 5 related patient safety quality indicators which shall be measured and reported by hospitals to the public. Similar to comments received on public reporting on staffing compliance in the prior section, some comments cited administrative burden and suggested alternative methods for reporting on the quality measures identified by the Commission. As in the prior section, we recommend clarifying DPH's role in determining the appropriate form and manner for reporting on the quality measures. We further recommend simplifying the requirements for hospitals to post on their website to require posting of the reports provided to the department. And if there are no other questions here, I will turn it over to Lisa for discussion of the specific quality measures.
Great. Thank you, Kate. Thank you, Commissioners. As Kate explained, the statute requires the HPC to identify 3 to 5 related patient safety quality indicators to be measured and reported by hospitals to the public under the law. As Lois outlined, the HPC engaged in a thorough regulatory process with extensive stakeholder and public input in order to first identify appropriate selection criteria for the quality measures, and second, to apply those criteria to potential ICU nursing sensitive quality measures to make a final selection for reporting. Stakeholders initially identified 11 possible quality measures for measurement and reporting by hospitals. Following the December 10th, 2014 QIPP committee meeting, you directed staff to request further comments on the 11 measures, applying the following criteria for selection. First, we explored whether the measures were evidence-based, standardized, validated, and nationally accepted, and therefore capable of benchmarking over time. The second criteria for selection was whether the measures were currently collected and reported by Massachusetts hospitals and the extent to which those measures were currently collected and reported. The third criteria for selection was whether the measures were nursing sensitive. And fourth, to the extent feasible, we asked commenters to provide information as to whether to the extent feasible, the quality measures would apply across the range of ICU types. Based on extensive stakeholder comment on the 11 quality measures we initially considered,
The QIPP committee at the March 4th meeting selected 4 measures for further public comment. Those measures are reflected at the top of the slide. The measures where we sought further public comment were catheter-associated urinary tract infection, CAUTI, central line-associated bloodstream infection, CLABC. The third measure where we sought public comment was all patient falls with and without injury. And the fourth was hospital-acquired pressure ulcers. During the public comment period, the HPC received comments on all of these 4 quality measures and also received suggestions on additional quality measures that should be considered. There was a consensus among all of the major stakeholders supporting the selection of CAUTI as a measure, and a consensus recommendation that instead of patient falls with and without injury, that patient falls with injury was a more sensitive, appropriate indicator of nursing care. And in addition, the majority of commenters supported measurement and reporting of hospital-acquired pressure ulcers and CLABC, including MNA's own expert with some reservations. Accordingly, the staff is recommending that these 4 proposed quality measures at the bottom of the slide be advanced to the full commission for consideration and reporting in guidance to be prepared following the promulgation of the final regulation.
So now, back to me. The next topic on which we received several comments is the timeline. But before we address that, which is the current, a new section 8.12, you will note that the red line version actually deletes the prior section 8.12, which was a section that required hospitals to develop a staffing plan based on the implementation of the acuity tool and compliance with the staffing requirements. Based on analysis of comments received, we agree that this section is unnecessary given the compliance obligations elsewhere in the regulation, and it is not expressly required in the law, so recommend its removal. So therefore, we've renumbered the timeline section as 8.12. We did receive many comments about the timeline in the proposed regulation, which required hospitals to seek certification by the Department of Public Health by September of this year. Given the process requirements of the regulation and the fact that the department will need to develop certification procedures, commenters asked for more time, some asked for an additional year, or other dates in 2016. We do recommend changing the timeline for certification and specifically wanted to respond to comments of non-academic medical center hospitals. So we recommend in this final regulation that academic medical centers comply with DPH requirements for certification by March 31 of 2016, and all other hospitals, which would include community hospitals, comply with certification requirements by September 30 of 2016, or on a different timeline if so identified by the department, because we recognize that DPH has a companion role in developing certification procedures and may need to take time to do so.
Great, thank you very much. Before we move on to just talk about first the process and then go back to the slide about definition, let me ask each of the committee members if you have questions about anything that Lois, Kate, and Lisa have gone through in such an extraordinary way in terms of giving us the background, a summary of the input and the current recommendation. So let me just entertain questions. Questions and comments. Short speeches if necessary.
Thank you, Madam Chair. I just want to congratulate you on the work that you've done and say that I think that the changes that have been recommended are all really very good. So I particularly appreciate actually the change in the title, which I think is very appropriate. And also removal of the at all times, which was bothering me right from the get-go. So, so thank you for the hard work that you have done and for the input of everybody that led to those outcomes.
I think it was particularly helpful to those of us on the committee to have you clarify where our choices are limited by statute. Because I know that during the hearings, there were a lot of comments on issues that when we really sat down, rolled up our sleeves and thought about how to change them, it was very clear we couldn't change them because that was how the law had been written. And second, what was extremely helpful was just identifying where we could make a recommendation, but at the end of the day, the Department of Public Health is going to have to either promulgate a sub-regulatory guidance or certification requirements so that we can be in a role of strongly recommending something, but that at the end of the day, we may not prevail. So it's always good to know where all of the hard work you put into something may not matter. Okay, and Veronica.
So, there you go. Lois, I am concerned that the red line version, 8.6 under development or selection of an implementation of the acuity to
Veronica, you may have to read that for the rest of us, if you wouldn't mind, unless it's 4 pages.
a lot of pages, but specifically the deletion of the environmental factors, specifically the other support staff that go into determining the acuity of the patient.
Yes, and sorry if we didn't make that clear in the presentation, but the intent was not to delete it wholesale from the regulation, but rather just to move that as a defined term. So all of the language that you see there is actually just in the definition section, which is 8.02, so which describes factors relevant to a particular ICU, which could include the physical environment, the skill mix, the availability of ancillary and support staff. So that concept is very much, and in fact that very language is still included.
Okay, thank you.
Alice, any questions?
No, I just wanted to comment and thank the staff because I came to this process a little bit later in time for the public hearings, but for the committee chair and Dr. Allen and the staff here just did a phenomenal job of processing what the legislature has asked the Health Policy Commission to do, which is not an easy task. And I think the changes that have been suggested so far, and I know we're going to discuss one more, are really excellent, thoughtful suggestions and a nice way of balancing the very different interests here.
Thank you. Marty, any questions?
I certainly come at this later than Alice does. And I want to commend the staff because someone coming into this midway, it was easy to see from the work that you've done, the changes and as well as some of the feedback and comments. One question though, have we had discussion with DPH about their ability to actually enforce these standards?
I don't want to speak for the Secretary and Alice, but we have had multiple discussions with DPH and are very, very mindful. As you know, this is a very unique posture where the legislature asked the Health Policy Commission to come up with certain regulations and DPH others in terms of implementation of this law and ensuring compliance. And so we have had those conversations, and I think that's why we wanted to sort of maximize deference to DPH as to how it will effectuate that and allow flexibility for them to do so in the manner they choose to.
And just to speak to that, because I was able to participate in some of those discussions, the law does very clearly give to the department the job of certifying, and therefore also compliance. So it is something that the department will be doing and will be considering.
Thank you. Let me make just a comment and a note about the next steps and the process. We are going to vote today on moving these regulations forward to the full commission at the June 10th meeting. Because we're about to have this discussion on the definition of the intensive care unit, if you will quickly turn to page 34, and for the audience, we will come back to this slide. I do want to highlight midway through the motion that we will be discussing in a moment, the committee will recommend further discussion by the full commission on the definition of intensive care units. So we will have a discussion of that here today so that we can bring out and highlight ideas, thoughts, reactions, and opinions that we have about it, but that we will not be making a final decision today on that definition. We will be recommending that this be a specific discussion held by the full commission. So with that as a preface, if we could turn back to slide 20 in our books, and you will magically move us back to...
I will, because
Thank you so much. Back to slide 20. Lois, again, thanks for being willing to defer this. And we will finish at 12:30, so we have 30 minutes for a full and complete discussion of this difficult issue.
Great, thank you, Wendy, and glad we're going to have some time to talk about this because it certainly raises a host of issues. Just to frame, the statutory patient assignment limit applies to all intensive care units. The statute provides that the term intensive care units shall have the same meaning as defined in 105 CMR 130.020 and shall include intensive care units within a hospital operated by the Commonwealth. And for that latter phrase, DPH's Shattuck Hospital is the only Commonwealth-owned hospital with an ICU, so that is not an issue of interpretation. The regulation that is referenced in the law, which is 105 CMR 020, is the definition section of the DPH hospital licensure regulation. The term intensive care unit is included in the definition of services in that section, as are several other specialty ICUs, including coronary care unit, or CCU, pediatric intensive care unit, PICU, neonatal intensive care unit, known as NICU, and burn unit. As you recall, based on a reasonable interpretation of both the statute and DPH hospital licensure regulation, the proposed regulation did adopt an inclusive definition of ICU, which included adult ICUs as well as PICUs, NICUs, CCUs, and burn units. In addition, based on consultation with the Department of Public Health, the inclusive definition of intensive care units we understood to be consistent with DPH's own interpretation of its licensure regulation and regulatory approach to intensive care services. Hospital commenters throughout this process, including the Massachusetts Hospital Association, Organization of Nurse Leaders, and several individual hospitals, raised significant concerns with the proposed regulation's inclusion of units other than adult intensive care units. Hospitals objected on legal grounds to the inclusion of NICUs, PICUs, CCUs, and burn units because such units are separately defined in the licensure regulation. For example, NICUs and PICUs are further defined in 130.601 and 130.750J respectively, and currently they do require 1-to-1 or 1-to-2 staffing for critically ill patients in those units, either pursuant to a regulation, which is true for PICUs, or applicable professional practice guidelines, which is true for NICUs. Beyond these legal arguments, hospital commentary focused on, especially on policy and operational implications of the application of the nurse-to-patient staffing ratios to NICUs. They argue that from a clinical, operational, and patient need perspective, NICUs ought to be exempt from the regulation, arguing in part that the application to NICUs would adversely impact access to quality of care for neonates. Specifically, with regard to NICUs, hospitals cited the fact that there were only 10 NICUs in Massachusetts, 4 of which are outside of Boston, and they treat a wide range of patients, some of whom are not critically ill. Given the unpredictability of volume, they asserted that the application of the law to NICUs would result in NICUs being unable to accept emergently transferred patients, or result in the separation of mothers from babies or multiple babies. While the hospitals asserted similar access and patient flow rationales for why the law should not apply to the 8 PICUs in Massachusetts, they did not assert specific clinical, operational, or patient need justifications for the exclusion of cardiac care units. Rather, they are relying only on the legal arguments that CCUs were separately defined in 130.020. Other commenters that we heard from disputed the narrow interpretation of the applicability of the law, saying that as reflected, for example, in the legislation's title, it was intended to cover all ICUs, noting that the law contains no explicit exceptions or otherwise indicates that it should apply only to adult ICUs. So as Wendy has indicated, given this extensive commentary on the definition of intensive care unit in the proposed regulation, including the alternative legal interpretations suggested and the significant care delivery and cost implications asserted by the hospitals about the application of the law, especially to NICUs, staff does recommend further discussion among this committee and at the full commission meeting on June 10th to ensure that commissioner input on this very important issue, because the definition of ICU really sets forth the application of this law and to which units do the patient assignment limits apply. So as laid out, the vote of the committee to advance the recommended regulation does reflect the recommendation of this need for further discussion.
Thank you. That was extremely helpful. And I think this is a little bit different from all of the other issues that you went through earlier, in that it is foundational. And many of us may be happy about some of the specific issues and how they were resolved, and unhappy about others, but they are not quite as important as the definition of to which units do all of those other regulations apply. So from my perspective, we have 3 different areas to comment on and to think about, and Lois has just done a terrific job of outlining them. The first is what is the legal interpretation of an intensive care unit? And there are differing interpretations of the law, and I think, as Lois has pointed out, different sections of the law in different parts of our kind of common, in different parts of the Commonwealth's government. Second, there are important policy issues, both for the nurses and for the hospitals, that we need to take into consideration. And third, not just the hospitals, but also Governor Baker and Secretary Lepori have been very clear with us that they are extremely concerned about cost implications. So I would invite the committee members to comment and or ask questions, clarifying questions about this particular proposed recommendation in any of those 3 areas. Veronica, would you like to begin?
So, Lois, if you could, explain the difference between, or the way that it is written in the law, the difference between the definition of an ICU and a CCU and the NICU.
We only have half an hour. So as I mentioned, the statute refers to a section of DPH regulation. And that is the regulation that governs hospital licensure. In that regulation is a definition section, which is the one cited, 130.020. There are certain defined terms there. One of those terms is services, which is the different types of services that DPH licenses for an acute hospital. In that definition of services, there are a number of names of different services, and included there's a definition of intensive care unit, which you might read as a sort of a broad general definition of intensive care unit. In addition, there are also listed within there is neonatal intensive care unit, pediatric intensive care unit, a burn unit, and a cardiac care unit. And so the issue is, how does one interpret the reference to that regulation and those terms defined in there? As I mentioned, the terms neonatal intensive care unit and pediatric intensive care unit, there in that section say they're further defined, and they reference other sections of the regulation, which, as I understand, came into that regulation at a later date, but are defined more fully elsewhere. So that's a bit of the sort of regulatory framework and some of the issues around complexity of interpretation that we're in. The reason I think initially we feel and still feel that is a sound interpretation to be all-inclusive is because the term intensive care unit is included in the very title of a NICU and a PICU, and a cardiac care unit is defined as an intensive care unit that serves cardiac patients. So that's the issue. And I think the legal interpretation or analysis of the hospitals is that because it's a very specific definition of intensive care unit that doesn't incorporate pediatric, cardiac, or neonatal or burn units, that really just refers exclusively to adult ICUs.
So when the legislation that we're dealing with was written, they did not make those distinctions. And that's why we're here today. Alice.
So this is a challenging task for the Health Policy Commission, and certainly Health and Human Services, including discussions with the page, have looked at the definition and looked very carefully at the submissions of the Mass Hospital Association and others with respect to how to define intensive care units. And it is not, I would say, a straight path once you look at the DPH regulations, and I would note that the government, per the governor and lieutenant governor, are going through a complete review of the regulatory provisions in place, and that would include this particular provision. Intensive care units, though, are, by their very name, intensive care units, and are defined in the regulation. And so to the extent that the regulation more broadly applies throughout it in additional provisions, which Lois rightly notes came into being after some of the initial definitions, those units are still referred to very specifically as intensive care units, still very specifically apply to critical care and specialized staffing and specialized physician necessary in the units at times 24/7. Again, those provisions aren't necessarily equally applicable to each type of unit, but they are intensive care units. They are there, at least under the DPH definitions, to provide for critical care, and therefore separating out specific units may be a difficult task. But I'm pleased that we're having this discussion, and I think it's a great discussion to have, especially in the context that Dr. Everett set out for us, which is not just legal interpretations, but policy determinations, as well as how it's affecting all of the people who are involved in ensuring patient safety.
Thank you, Alice. Marty, I'll give you a moment to think, and we'll go to Carol.
Thank you, Wendy. So you talked about 3 domains. I cannot comment on legal. I'm a doctor, not a lawyer. And I am, but the other 2 areas, you talked about policy. What you didn't talk about was the patient's perspective, which I think we have to keep in mind. And maybe that's part of policy, I'm not sure. And also just operational issues, which may go along with cost. But we have a principle in medicine, do no harm, first do no harm. So I think we have to be very cautious not to put in regulations that may create undue burden or undo good processes that we already have in place. And I also think we do have the opportunity to use some time to implement these things. So all of that as background. The thing that most concerns me are the NICUs. I just, from all the testimony that we've heard, from my own personal experience as a pediatrician, I'm having great difficulty understanding how NICUs actually can fit into this regulation. I looked up in the pediatric literature. There are a number of articles about defining what different levels of NICUs are, what their staffing should be. There's a 600-page guidelines for perinatal care that was produced by the American Academy of Pediatrics and ACOG, and which I'm sorry to say I've only read part of it, but I have it, and I feel as if they already spell out the what the standard of care should be in a NICU, and for us to sort of override that and put in our own is really almost presumptuous and could be dangerous. I feel as though there's the composition of staffing within a NICU is very different. It's not like, you have the nurse and the doctor and maybe an NP, but you may have a neonatologist, you may have a resident, you may have a fellow, you may have specialized nursing, and they all collaborate in the care of babies. And then there is the family piece, where the family is part of the team. And there needs to be an allowance to include family members, including a twin or somebody else who may not be a level 3 or patient, but needs to be cared for together with that other twin for the integrity of care. So I don't know if it's feasible to say exclude NICUs, but include cardiac care units. I can't comment on those other things. That's one thing I think we should discuss, but I really feel very strongly that we should go slow and exclude NICUs at this time until we've had some experience with ICUs in general.
Just to add one piece to that, although the legislation said intensive care units, there is a sophistication, as we all know, to intensive care units, particularly in NICUs. And there's a huge difference between a level 1 NICU and a level 4 NICU, which is not something that we would necessarily expect a Senate president in any state to be knowledgeable about or understand. So I think part of our role in promulgating proposed regulations is to help educate the people who will be implementing those where there are subtleties. And I'm not saying that they are across the board. Marty?
So I get the arguments that Carol so eloquently stated. But I went back and looked at the statute, and the word that trips me up is all. And I don't know if we've gone back and looked at what the legislative intent was and whether that was included. Was that meant to just be adult, or was it to include these others as well? And I think it's hard to know just looking back, but I also then worry about if we exempt one, do we then have a sort of cascading effect with pediatric intensive care units, burn units, and so forth. So it's a tough issue. I'm not sure I know the answer.
I mean, and
Veronica?
in fact, if you look at the, the policies, DPH definition and policies of each of the units, they clarify that they are in fact an ICU and staff 1-to-1 and 1-to-2 already. Right, so
I think the PICU is not the NICU.
not the NICU.
That's correct.
But
I think
and the
the staff-
CCU would definitely be under those definitions.
Right.
So right, and just one of the sort of nuances here is that, you know, for most ICUs, and especially with NICUs with the perinatal guidelines, and in the DPH regulation for PICUs explicitly, there is a requirement that it's 1-to-1 or 1-to-2 staffing, but that applies to the critically ill patient. And I think one of the issues that's raised and that has been cited in terms of increased cost implications of this law is that because of the unit-wide applicability, it will require staffing all of the patients in the unit, whatever that unit is, regardless of their acuity, at 1-to-1 or 1-to-2.
So the implication would be that they are boarding patients in the ICU that are not critically ill.
Or that they may have received a baby that, it's often good practice to put multiple birth babies into an ICU until you know they're stable, but they may not be critically ill. Each of the babies may not be critically ill, that's correct. So, there's been in general, 1-to-4 required staffing ratio, and that could be 1-to-1 for a baby who's just had heart surgery or mitral valve repair, or it could be 1-to-4 for babies that just need a fair amount of watching.
And specifically with respect to NICUs, the testimony is that it's the issue of there being co-located level 2 child and maternal services and level 3 NICU. So NICUs refer to the levels 3 and 4, but many hospitals, as we understand it, have level 2s and 3s together.
And then the other issue is just the fluidity of change, and it can be so quick and so sudden, and we get called to a delivery, and then you have another delivery, and then the transport team has to go out and get a baby. I mean, there's just so many things that happen so quickly that, and our NICUs do a really good job now, so I think we need to be very cautious not to do something that would harm the system that we already have in place. I'm not saying we shouldn't look at it, but I just worry that if we include the NICUs, we will be causing a problem that we didn't want to cause.
Any other questions, comments, things that you would like the staff to clarify or get more information about in the next 3 weeks. Okay. I want to now move us to the slide where we are going to take a vote on the motion. You have the motion in front of you. It is slide 34 in our books. Okay, we're there, thank you. So let me read this because it is important. The motion is that the Quality Improvement and Patient Protection Committee approves the advancement of the recommended final regulations on patient assignment limits for registered nurses in intensive care units in acute hospitals, developed that were pursuant to Section 231 of Chapter 111 of the General Laws, provided that the committee recommends further discussion by the Commission of the definition of intensive care unit and recommends that the Commission vote to approve and promulgate 958 CMR 8.00 at its meeting on June 10th. Second. All in favor?
Aye.
Any opposed? Thank you.
Madam Chair, I wish to
Yes.
abstain, having not had the pleasure of all of the public input.
Thank you, Marty. One abstention. Thank you very much. Okay, again, special thanks to the staff. Carol may think she's a pediatrician. At the end of the Sunday minutes, she's also an attorney. Thank you for those of you who not only attended today, but have helped us come to this point in time. And we will ponder this for the next 3 weeks and see you at the full commission meeting. Thank you.